Hello and welcome back to Bedside Murmurs, a podcast where we chat with doctors about their careers, pathways in medicine, clinical tips, and much more. If you have any questions or if you have any ideas for guests you would like to see on the show, please email us at podcast@medsoc.org.au. That's podcast@medsoc.org.au. I'm Sean.
And I'm Emily, and we will be your hosts. Today we have the pleasure of speaking with Dr Pramudie Gunaratne, who is a clinical neuropsychiatrist and research fellow at the Department of Developmental Disability Neuropsychiatry at UNSW. Dr Gunaratne is the current New South Wales branch chair for the Royal Australian and New Zealand College of Psychiatrists and has had various experiences working with the World Health Organization and other health organizations. She is a passionate advocate for equitable and accessible psychiatry services for all. So welcome.
Lovely to be here.
So could you tell us about your experiences at medical school?
Yeah, sure. So I studied at UNSW and I did an arts medicine degree, which I really, really loved. So I feel like this is a great university to study at. And I remember when I was finishing high school and sort of thinking about what I wanted to do, I know my head kind of told me that medicine was a very sensible, well-respected profession and that's what I should do. But my heart probably really wanted to learn more about the social sciences and the arts. And so when I sort of found out that you could do an arts medicine degree at UNSW, it was a bit of a game changer because it meant I didn't really have to choose, which was great. And I think as I did my degree, I sort of realized that the two areas really, really complement each other rather than necessarily being like two totally different areas of study. And so I really, loved being able to do bits of both through med school.
Yeah, 100%. The arts medicine course is quite a long course. So most of us that go through medicine is a 6-year degree. I think in your year it was like maybe a little bit shorter, but adding an extra degree on top of that increased the uni timetable by quite a lot more. What kind of decisions went through your head when you went through choosing a degree that would be 8 or so years?
So fortunately for me, it was 7. So it's only one extra year. And I guess if you really love something, it feels like it's worth that extra time. And I think, particularly at UNSW, we go into med school straight after high school. We're still really young. So, and everyone's career path takes so many different twists and turns. And so I think, in the grand scheme of things, 1 or even 2 years is not really a huge deal. There's lots of people that take gap years and all sorts of other kind of changes in their career. And so I think for me, it didn't feel like that extra year was a really big deal. And I certainly don't regret doing it. So I'm really happy about that choice.
And what did you major in with the arts degree and how did that complement medicine?
Yep. So my major was international relations. For me, I think I really cared about sort of social justice, and as many medical students do. We go into this profession because it's a caring group of people, and I also really wanted to understand systems better. And I guess in medical school we learn about how we care for the individual patients that are there that we care for. But then when we think about, there are all of these sorts of social, environmental, economic, system issues that mean that patients land in our emergency departments or our clinic rooms or our operating tables. And so while it's awesome to be able to help each individual patient, sometimes it's really good to be able to zoom out and to look at those more upstream things and what affects health and well-being in a more sort of general sense. And so for me, doing that international relations, social sciences degree helped to understand or have a framework for how to think about those problems.
That's really exciting, especially because in medicine, we tend to cycle really far into the clinical sciences, and then you kind of lose sight of the world outside, and then you don't really get the public relations aspect of it, which is so important in medicine as well.
Did you have any experiences in medical school that got to touch on those interests that you did with international relations at all?
Yeah, so so I was really fortunate. I was able to negotiate with the faculty to sort of put together my elective, my selective, and a little bit of holiday time together. And so I ended up doing an internship at the WHO in Geneva while I was in medical school. And that was with the Department of HIV/AIDS. And it was an amazing experience because I got to work with this wonderful team. And the project that we worked on was the WHO was updating their guidelines for looking at different key populations. There's 5 key populations for HIV/AIDS and how they can improve sort of diagnosis, treatment and care for those patient groups. And so it was, something that I didn't really have a lot of exposure to in medical school. And I think that really set the course for really enjoying that sort of non-clinical part of medicine as well.
And what was it like working in such a large organisation that was looking at things internationally? Did it seem like it was very different to how health systems work in New South Wales, or was it pretty similar?
I guess it's different because it wasn't a clinical role. And the other thing that was quite interesting about it was the mix of people that were there. So there were sort of the teams include people from all different parts of the world. And one of my jobs was to look at case studies for key populations. And so then it was a lot of sort of liaising with sort of people that were working in the field in different parts of the world and trying to understand how care was provided for people with HIV/AIDS and different like innovative models for how care could be provided in different parts of the world. And so that was really interesting. And I think also Geneva is this sort of like melting pot where particularly when you're an intern, there's all these interns that are there. Sometimes they're medical students, sometimes they're sort of from different areas of health or outside of health. So that was really interesting as well, kind of having all these different lenses that you use to look at the same problem. And I think I learned a lot from all those different perspectives.
This might sound like an interesting question. I'm approaching it from the fact that like I do a little bit of stuff in terms of societies at multiple different levels. When you make a healthcare policy or you try to make decisions at an international scale compared to a national scale compared to a local or statewide scale, what kind of different considerations do you have to go through?
I mean, I guess there's probably, I guess when you're thinking about policy at an international level, I guess one of the main constraints would be the different amounts of resources that different countries have. And I think particularly when it comes to the WHO, a lot of the policies are designed for resource poor settings because they may not have the infrastructure to be able to develop policies in each of those areas. And so that's one consideration about the practicalities of what's possible in different health systems. And then there's also different cultural considerations in terms of what's appropriate in certain parts of the world that may not be appropriate in other parts of the world, or sensitivities. And then I guess there's politics that are involved in some of that as well. And so I think those things are probably the differences, but there's heaps of similarities as well in terms of, best practice is best practice. And that's what we're aiming for. And it's how do we provide that care with the resources that are available and kind of aspiring or aiming towards providing the best possible care.
So in light of all the experiences that you did have in medical school, what was your trajectory after that?
Yep. I think I've had a bit of I call it the scenic route after finishing medical school. I mean, in some ways it was accelerated, in some ways it was a scenic route. So I did my internship just up the road at Prince of Wales Hospital. And then straight after internship, I knew that I wanted to do psychiatry. So I went into the psychiatry training program, which I don't think you can do anymore, but at that time you could. And after doing the first year of psychiatry, sort of acute inpatient ward, so I did my first year. And I guess I'd sort of gone from high school to medical school to training. And so I wanted to have a gap year. And so I took a year off, and there were a whole bunch of things that I really wanted to do, like learn French and live in France and
very valid
creative writing in New York City and backpack through South America. So I kind of spent a year doing
That's amazing.
some fun stuff
so cool.
that I really wanted to do. I think I was really lucky to be able to do that. And one of the great things about being a junior doctor is that you can locum. And so when you do some locum work, you can sort of save up enough to be able to, take a year off and travel. So that's a really, great thing that we have available to us. There's so many opportunities to be able to do that. And so, it took my year off. And I know a lot of people sort of, think that there's kind of a race with medicine, and you've got to it's going to stop you from being able to enter the training pathway that you want to. But to be honest, in psychiatry, it's really encouraged for people to be able to have all these different experiences. But even friends of mine that have taken a completely different route in medicine have taken years off. So I really sort of encourage people not to to be too sort of caught up in the pathway, and to try and do the things that you need for you at that time. So even, friends that have gotten into orthopedic surgery have taken time off for various reasons, and it's totally fine to do what you need to do as you go through your medical training. But after doing that, I came back and got back into training, did a couple of years of my training, and then I was really interested in doing more work in public health. So I started a Masters of Public Health through the London School of Hygiene and Tropical Medicine, and did that through what's called a blended learning method. So part of it was by distance and part of it was in person in London. And that led me to then doing some work at the WHO as a consultant this time rather than as an intern.
Oh, wow.
And so I did a year of that and then came back into training just as COVID hit.
Right on
back
time,
in Australia,
right on time.
and finished my psych training. And since then I've been working as a neuropsychiatrist.
Oh, wow.
How has your kind of experiences either in the WHO and also just taking a year off changed the way you practice now?
Yeah, I think the more experiences that you have, the more kind of tools that you have to be able to understand your patients and their experiences, but also to understand the systems. Because I think often, when you're working as a doctor, you really want to be able to give your patients the best care that's available. But even, we're in one of the wealthiest countries in the world, there's still resource constraints. There's still like a system that we have to work within. And there are rules and cultures and hierarchies within those systems. And so I think if you kind of can zoom out and understand those systems a bit better, you can understand how to navigate those systems. And that will allow you to be able to help your patients access what they need and also help you as a clinician to be able to make your work more satisfying and enjoyable. So I think maybe having the different lenses has helped me in navigating the systems a little bit better.
So why did you decide to become a psychiatrist?
That's a good question. I think when I was in medical school, I had like zero interest in being a psychiatrist. I probably didn't even know what a psychiatrist did really. Like I kind of knew there was like something about a couch and you probably talked a lot to patients, but I had no idea what a psychiatrist did. And because I was really interested in public health, I thought, okay, well, people that do public health often do like infectious diseases or ED medicine or something like that. So that's probably what I would do. But as I went through medical school, like I liked most things, but I didn't really love anything. And as I was going through, I was like, oh yeah, I'm probably do one of these things, but I'm not really sure. Until my final year, kind of halfway through my final year, I did my first psychiatry rotation. And that was like a sort of mind blow moment for me. Like it was, I really loved it. And I always remember like I was allocated to Prince of Wales Hospital at the inpatient unit there. And on one of the first days in that term, there's a little group of us medical students that were allocated to the ward and we were sort of ushered into this interview room. I don't know if anyone's been on Kylo. It's a bit dilapidated. It's this like really grungy looking like interview room, definitely not like a therapeutic space. And we had this consultant, Dr. Gavin Edimer, who became a supervisor for me later in my training. But he was interviewing this patient and this patient was floridly psychotic. And
that's the best adjective I could ever hope for.
And it was like a moment where I like really, really definitively remember that because I had never seen anything like it. And I think I really like the spark for me with psychiatry was kind of twofold. Like one was that I was really taken aback that the mind, which, we as medical students, like we take medical students or doctors, that's something that's so integral to us, but for everyone, your brain is so linked in with you as a person and your identity. And it was really confronting for me that something could happen to alter and shift that in such a profound way. And I really wanted to learn more about, what is it that happens to our brain and our mind that can make such a central part of who we are as individuals change so significantly. And so I think the pathology that's involved in psychiatry really interested me. But then the other part of it was the consultant who was interviewing the patient was doing it in such a compassionate and kind way. And it was one of the first times in medicine that I saw a senior doctor really connect and really aim to kind of understand the whole person. And that really resonated with the type of medicine that I wanted to practice. So I think for me, that's why I've sort of really loved the field.
Yeah, that makes perfect sense. It's interesting because psychiatry is like the blend of the sciences in the sense that you have a lot of like talking therapy, but also there's pharmaceutical means that you can rely upon as well. And it's essentially you go in with your repertoire of tools to try to help the person itself as opposed to treat kind of diseases, which is really, really interesting. It's almost the essence of medicine distilled into an art form.
Yeah, beautifully put.
So I think you've mentioned that there are different types of psychiatry specializations that you can pursue with the training programs. What are the possibilities for a career in psychiatry?
It's endless, really. There's so many different options. In terms of like formalized pathways, so when you do your advanced training, you can choose to do a couple of different certificates. So there's child and adolescent psychiatry, there's old age psychiatry, there's forensic psychiatry, there's consultation liaison psychiatry, which is when you provide consultation to the general hospital kind of medical and surgical wards. So there's a few that you can do that has a certificate attached to it. And then there's a whole range of other ones that you can do where you develop your advanced training in a way that allows you to develop specialized skills in that. So, and those often internationally would be recognised as subspecialties, but maybe in Australia we don't have a recognised certificate or pathway. So neuropsychiatry is what I do, and that's one of those ones. Like perinatal psychiatry is another one. But then I think there's a whole range of different types of psychiatry that you can practice as well in terms of, do you do telehealth? Do you do more psychotherapies and talking therapies? You're someone that does procedural stuff like ECT and TMS. And so I think there's just like a range of things. You specialize in medical legal work, and then do you do criminal or do you do civil? So there's lots of options. If you do research, there's lots of opportunities as well. So I think it's really what you make of it and what you're interested in.
Which part of neuropsychiatry drew you towards that?
So I first, sort of my first interaction with neuropsychiatry was at the Neuropsychiatric Institute, which is also at Prince of Wales Hospital, and realising a lot of my formative years were at
Prince of Wales.
Prince of Wales, not too far from here. So again, I think the thing that interests me about neuropsychiatry is it's looking at people that have organic pathology, so whether it's a traumatic brain injury or an intellectual disability or whether they've got, Parkinson's disease or dementia. So there's something organic that we can see that's going on in the brain, and that leads to a psychiatric issue. And I often think it's a bit arbitrary that we divide in modern day society the brain and the mind, whereas neuropsychiatry kind of treats it as one. And I think it's really important to understand the biological basis of the brain if you're going to treat the psychiatric aspects of the brain. So I really feel that neurologists should be neuropsychiatrists and psychiatrists should be neuropsychiatrists, and there's this kind of spectrum between the two, but they're really very, very interlinked.
And what do you do day to day as a neuropsychiatrist?
Yep. So I spent half of my week in a clinical role, so working in a clinic and seeing patients, and then and that's at a private practice. So so see the patients,
which is beautiful and very well decorated.
You did see it during when we had our first discussion. A little bit more therapeutic than the Kylo ward, I'm hoping. And then the other half of my week I work at UNSW at the Department of Developmental Disability and Neuropsychiatry. So that's a research policy kind of role, a little bit of teaching involved in that. Yeah.
So when you're working in clinic, how many patients do you typically see in a day? And for a lot of our listeners, they're normally in preclinical years. They may not have an idea of what it's like to, go on into hospital or go to clinics. What's it like actually being with patients and chatting with them and treating them?
Yeah, it's a good question. So because we see neuropsychiatric patients that often are quite complex in the sort of pathology that they have, but they also come with a team that are involved in their care, we probably take longer to see patients than you generally have in psychiatry. So we leave 2 hours to see our new patients and then an hour for each of the follow-up patients. So if you've already seen them before and this is a follow-up appointment, we'll leave an hour. So usually I'd see about 8 patients in a day. But if you're working in a more general psychiatry clinic, maybe you'd see like an hour for new patients and maybe it's half an hour for follow-ups. But everyone's really different and it's the pace that kind of suits you. So that probably gives you a rough estimate in terms of the numbers of patients.
What do you enjoy most about psychiatry?
I think I enjoy a lot of things about psychiatry, but probably this is really tough. I'm trying to competing things in my brain. I think I really love that when you see a patient, part of the therapeutic kind of alliance is that connection that you have with that patient. And I really love being able to get to know my patients in a sort of broader sense beyond just the sort of diagnosis or the pathology that they come with. And you kind of get to walk with them through that journey into recovery. And I find that really fulfilling to be able to kind of, you know, it's not like they're your friend, because it's a very different relationship when you're their doctor, but you do get to get that kind of connection with a person and move with them, and I think that's a really it shouldn't be a unique thing with psychiatry. I think all doctors should be able to connect with their patients. That's a really important part of that therapeutic alliance with the patient and helping them, but it is something that we focus a lot more in psychiatry, and so I really enjoy that.
It's like a therapeutic relationship is the best way to describe. Ben describes
That's
it
what Ben
always.
describes it as,
Like the therapeutic relationship that you have with your patients.
Yeah.
This is going to sound like a very interesting question. Like I have lots of those. But when you see your patients, what are some non-pharmacological therapies that you found to be surprisingly effective in their care?
Surprisingly effective.
Or what you wouldn't expect?
Yeah. In terms of non-pharmacological, so I guess, I kind of already mentioned the therapeutic alliance, like that is really important, because I think, and it probably acts in other areas of medicine as well, but if your patients really trust you, if they feel that you're there to help them, I think that can go a really long way in terms of helping them through whatever the illness would be. And it's really, it's something that's very simple, but it's actually really profound and really, really helpful. And I don't think I've quite appreciated how important, like, we as a person, like we are in terms of that relationship. Because when our patients come and see us, you know, there's this huge power imbalance. You know, they're in a really vulnerable situation. And they
like, help us.
Yeah, and they're here to see you, and you're the person that has the answers. Sometimes you won't have the answers. Sometimes you make mistakes. But if you have that relationship with them, then you can really meet them where they are and help them. And I think that's something that I've learnt more and more as I've kind of progressed through medicine, is how important that communication and that connection with patients is.
100%.
It's an interesting question though, Sean, because we asked for some audience questions before this episode, and a lot of the questions were asking about whether psychiatry is currently overprescribing or underprescribing medications for different conditions, as well as opinions surrounding new therapies, so such as using what might be normally called like party drugs like MDMA in psychiatry. So there seems to be a lot of debate and discussion in medical students about what actually is psychiatry, how much do we rely upon talking therapies, how much do we rely upon pharmacotherapies, and actually what does it mean to be a psychiatrist who practices well and puts your patients at the centre of care. So one question from the audience was, do you think that psychiatry currently overprescribes or conversely underprescribes different pharmacotherapies?
Yeah. I actually think the answer is both.
Okay.
So I think
that makes sense.
There's a huge problem in terms of access to good mental health care in Australia, everywhere, but also in Australia. And I think that means that it limits the availability of good quality, whether it's pharmacotherapy or other therapies for people. Part of that's to do with the shortage of psychiatrists, the lack of services that are available. You know, in Australia, we talk about the missing middle in psychiatry, which is that if you've got sort of mild illness, then maybe you'll be able to see your GP or a psychologist and get access to, you know, the 10 sessions or whatever it is that Medicare allows you to have. And then if you've got really severe illness, then maybe you'll be able to enter a public service and you'll be able to go to an inpatient unit or community mental health team. But there's a whole lot of people in the middle that don't meet the criteria to enter a public mental health service, but they can't really be treated adequately with, you know, a GP who's very time limited in their ability to see patients and maybe doesn't have the skills to be able to treat people that are more severe. And so I think there's a whole lot of people in Australia that don't access good quality care. And so for them, there's definitely under-prescribing or under-treating. But at the same time, I think there's also probably a group of people where a lot of problems that they would come to you with are not going to be fixed with a pill. And I think part of the art of psychiatry and the science of psychiatry is to be able to tease that apart and to help people understand, you know, when it is that medications are going to be helpful and when it is that other things are going to be helpful. So I think it's both, if that makes sense.
That makes sense. 100%. Yeah. It's a very insightful idea.
Okay, so
I think that's true with most specialties as well. You have an unprescribed missing middle where the most people that don't actually have as intensive a pathology can be dealt with and managed with in a very acute and subclinical setting. When you have a very large problem, you get an MI or something like that, you start to have problems. But the people that have the middling diseases where they're just not sick enough to go to hospital, but not well enough to be perfectly fine, is when they start to really deteriorate. And unfortunately, a lot of what medicine does is it treats people at the very, very end of the pathology, as opposed to the middle part where they could do a lot more health and get a lot more benefits.
Yeah, like stopping that progression. Yeah.
Have you noticed that in psychiatry there is also, like, if we can get to the people before they develop very major clinical symptoms of psychiatry, that if you get to them earlier, they will have much better outcomes?
Oh, absolutely. And I think that's the case for most types of pathology across the spectrum, from psychiatry to kind of physical health, is that the earlier that you can treat, the better the outcomes. That doesn't mean that you can't get good outcomes at a later stage, but it's definitely earlier to treat, easier to treat earlier. Yeah.
So what's involved in general psychiatry training and getting onto the program?
Yep, sure. So the training program itself is the quickest that you could do it, is 5 years.
Okay.
In terms of getting onto the training program, it's an application to the college. Generally, it's looked favourably upon if you've had some experience working in psychiatry. It's not essential, but it's good to do that, and it's good for you as well to know whether you want to do it or not.
Definitely work before you apply.
And I think it's like a CV referee. It's just like the usual application process as it would be for most specialty colleges. And then in terms of the actual training program, so the first year is the same for everyone. It's general adult acute inpatient wards. So it's inpatient psychiatry. And then after that, that's called stage 1. And then the next 2 years are called stage 2. And in stage 2, there's a couple of mandatory terms. So everyone has to do a child and adolescent term, and everyone has to do a consultation liaison term. But then you've got 2 that you can kind of choose the sort of different types of psychiatry that you want to do, which rotation. So as with most specialty programs, you move around every 6 months. And then after you do your 2 years of stage 2 training, then you're an advanced trainee, and that's the year 4 and 5 is advanced training, and you can choose to do a specialised certificate like we spoke about before, or you can do sort of choose what sort of advanced training you want to do. So that's the quickest that you can get through it, and there's a whole bunch of exams. I think we have like 4 different exams, and one of the interesting ones that we do is a long case or a psychotherapy case, which is where you see a single patient for a year and you do that kind of talking therapy with them for a year. It's called psychodynamic psychotherapy. But other than that, it's all the normal exams that you would expect with most specialty training programs. And often people might take a bit longer than that because they might choose to, do more experience in certain areas, or if you don't get through your exams the first time, which often happens as well.
A question of ignorance. What are the normal specialty exams?
Oh, sorry. So usually you'd have like an OSCE exam. You might have something
can you
like
talk to a patient? Yep.
Yeah, and you might have something that's similar to a Viva exam. You'd have a multiple choice exam. You'd have a written exam.
Okay.
All the same stuff that you would do in medical school.
Okay.
So
That
similar formats, but just
more advanced content.
Yeah, exactly. Yeah.
That brings a little bit of comfort. I was scared that there was going to be like a whole suite of new exams that we've never seen before dumped upon us as soon as we enter specialization.
One question from the audience was, what are your thoughts about the stigma that medicine often has towards psychiatry?
Yeah, I mean, I think this is hopefully a problem that's reducing, but definitely still there. And I think that acts on multiple levels. So there's stigma that our patients and even psychiatrists experience maybe from the general community, but there's also a lot of stigma within medicine towards psychiatric patients, you know, whether they're in the ED or on the medical wards, as well as towards psychiatrists. So I think that's a problem because it limits the access that our patients have to really good quality care if they're stigmatised and people don't want to care for them. But I think that more recently we've seen, particularly after COVID, a lot of people have had experience of potentially not like severe mental illness, but at least have an understanding for what, you know, for a degree of mental illness, or have people around them that have really had issues with their well-being. And so I think maybe there's a bit more of empathy and understanding to the fact that mental illness can hit anyone. And in fact it does. And it's awful that people don't feel like they can share their stories or talk about mental illness because they're worried about feeling stigmatized. And I think that's part of the role of being a psychiatrist is, you know, to help your patients and to advocate for them when you can see that that's happening, but also to advocate more broadly around the fact that, you know, mental illness is really normal. You know, it's like 1 in 5 people have some sort of mental illness, and that we shouldn't be afraid to talk about it. And I think the more that we have these conversations, hopefully the less stigmatized mental illness becomes.
Throughout your training and practice, how have you seen psychiatry and psychiatric symptoms and diagnoses evolve?
I'm not sure I've been in training long or in psychiatry long enough to like see huge changes in terms of how. So I guess the way that a lot of mental illness is defined is through the DSM, and so there's been multiple iterations of the DSM. We're up to DSM-5 at the moment. And so through my training, we've gone from DSM-4 to 5. So there's been one jump.
One iteration.
Jump. And I guess there's been lots of little changes in terms of how we say, you know, we define things like autism, where there used to be kind of Asperger's and then autism, whereas now we kind of look at it more as the an autism spectrum. There's level 1, 2, 3, and that's some definitional changes around how that works. And I guess the way that we conceptualize some illnesses, actually, one that's probably quite relevant to neuropsychiatry is that we're having a much better understanding about some of the organic bases for different psychiatric pathology. Unfortunately, what happens is that once we figure out what the organic kind of origin is, it gets taken away by another specialty. Like, for instance, you know, there's, you know, a lot of evidence around like encephalitis or autoimmune conditions that might lead to psychosis or sort of other mental health issues. And so then the treatment for those autoimmune conditions is more immunological than it necessarily is using like antipsychotic medications, although that can be part of the treatment. And so then it becomes kind of an immune-mediated illness that gets taken up by immunology.
Your jobs are getting capitalized.
Stolen.
Every time we figure out the cause, it leaves us. Not always, but that is one thing that we've kind of seen happen. There's lots of kind of discussion around kind of the gut microbiome and how gut health influences mental health. And I think we all kind of understand that there's this link between the two.
Oh, yeah.
Yeah. So...
when I eat bad food, I just feel worse.
Yeah.
I know it happens.
So yeah, there's I think it's quite exciting. There's lots of different possibilities and potential for having a better understanding about the organic basis of a lot of our disorders.
And do you think that that's where the future of psychiatry is headed?
I think so. Like, I think the more that we have tools to be able to really understand different parts of the body, there'll be something like a lot of psychiatry are syndromes. So we cluster different symptoms together and then we give it a label. whereas we don't necessarily have the pathological origin for those syndromes. And so I anticipate that as we understand some of the organic bases better, then we'll probably split those illnesses up into different areas, like autoimmune encephalitis causing psychosis versus schizophrenia, whereas in the past that might have been seen as the same thing because we didn't really know that was going on. So potentially we'll be able to, keep splitting things and understanding the different biological sort of underpinnings. But I think there's always going to be, because the things that happen to us biologically and all of the things that happen to us environmentally are so interlinked. And so I think we'll never really, even when it comes to something that seems completely biologically mediated, there's always going to be
stresses in life.
Exactly. And so I think that's where we'll continue to need kind of therapies and things like that, and particularly things like trauma and how that influences the brain, and how that influences how our personality forms and the coping mechanisms that we have. Those things are so nuanced that I'm not sure there's ever going to be like a specific biological marker or thing that's driving that. I'm very happy to be proven wrong, but it doesn't seem like it at the moment anyway.
Along that same vein, it's like almost there's a kind of competition between how much of it is really biologically seeded and how much of it is an environmental kind of insult into that as well. The thing that we usually get taught is most pathological diseases are a combination of an biological susceptibility or genetic susceptibility and an environmental insult that causes it to manifest in a pathological disease. I think that's really, really true with psychiatry, in the sense that especially with trauma, you tend to suddenly have a massive like emotional insult to your mental health and well-being, and if you're susceptible, you tend to have problems dealing with it. We had a coach on a few episodes ago.
Did,
and one of the things they said is like there's a kind of a really interesting relationship between psychiatry and coaching, and coaching is to do with how can you kind of help the person better comprehend their environment, and it's all about action words and the ways they can interact with the environment. How would you describe psychiatry's role in the helping of an individual?
Yeah, I mean, I guess often when a patient comes to a psychiatrist, they're probably at the point where they would benefit from some sort of biological intervention, as opposed to necessarily just doing, I shouldn't say just, the talking therapies are still really important. There are some psychiatrists that specialize in psychotherapy, which is the talking therapy, but that doesn't have to be a psychiatrist who does that. So psychologists, social workers, counselors can usually be trained or have specific training in different types of therapies. Whereas I think, so outside of psychotherapists, most psychiatrists I think would say that their job is different to sort of coaching or therapy, because it's a lot about diagnosis and being able to provide medication often to be able to help that person. Sometimes that's not the case, and I think that's when we would, if a diagnosis suggests that this isn't something that necessarily would respond to a medication, then we might refer to a psychotherapist, whether that's a psychiatrist or a psychologist. If that's something that's part of our practice, then we might do it ourselves, but often the psychiatrist will refer to someone that specialises in doing that.
That's really good to clarify, because I think a lot of people don't fully understand the particular roles of a psychologist and a psychiatrist. So thank you for clarifying that.
As well.
And a psychotherapist as well. So it's really good that we've been able to tease those apart.
Yeah. Oh, no worries.
Another question that we had from the audience was, how as a psychiatrist do you deal with the heavy emotional burden that can come with treating patients who may have more complex histories and conditions, and how are you able to separate that from your broader life, so containing your medical life with the rest of life?
Yeah. Look, I think this is probably something that affects all of us, but we probably don't talk about it as much.
100%.
Even, if you're like a surgeon and you see all this trauma all the time, like physical trauma, it can be really brutal, and it can, cause a lot of anxiety and fear. But we often don't talk about the impact of a lot of what we see day to day in terms of how it affects us as individuals and as doctors. And so I think it's something that it applies across the board. But one of the things about psychiatry, I think, is that we do talk about it and like in quite a formal way. Like when you're going through psychiatry training, one of the mandatory things that you have is weekly supervision. So you have your supervisor that has to have 1 hour, like one-to-one supervision with you, where you can talk about all of these things in terms of the it could be clinical problems, but a lot of it's also not meant to be about the clinical problems, but it's meant to be about the emotions that came up and what you observed and kind of understanding that. So I think we focus and we put some emphasis in being able to understand the emotions that are stirred up for you when you're engaging in the work that we do. In the sort of general medical field, you might have heard of Ballant groups. I don't know if that's been something that you've been part of, but Ballant, so B-A-L-L-I-N-T.
How do you even spell that?
I think that's how you spell Ballant.
Like ballet with an N?
I think Ballant is a name of a person, but
okay, that makes sense.
I could be wrong. I'm not sure actually. I have to check on that. But it's like it's a way for it's developed for doctors to kind of come together as a group. And it's got a specific format, and you kind of talk about your experience of caring for patients. And so I'm not sure most, but there are definitely some hospitals where interns take part in Ballant groups or junior doctors or, across the spectrum of medicine. So that's one way to kind of process some of those emotions and consider those things and how it affects us. But I think because we focus on it, it actually means that it's a bit easier to be able to process those things and understand it, and also just even recognize it happening within yourself. Because I think one of the dangers is that if you're experiencing this all the time and it becomes so normalized that you don't even realize the effect that some of these external experiences might have on you. I hope that answered that question.
That's a really that's a really powerful idea, that psychiatry is actually one of the safer ones, because you have the awareness that it is a dangerous kind of field, like mentally, and you deal with people with very complex health histories and more complex psychiatric histories. So it's always awareness that this is a work health like safety hazard that you should be addressing and noticing before it gets too much to bear. And there's always room for improvement, so it's not that psychiatry does it perfectly, but at least we kind of think about it a bit more, I think.
To wrap up, did you have any final encouragements to anyone who is considering a career in psychiatry?
I mean, I think it's, I'm very biased obviously, but I think it's a really great career to consider. You've got the opportunity to help a lot of people, to get to know a lot of people's stories. And it's a really it's an area of need where we definitely need more psychiatrists. And in terms of training, sometimes there's some difficulties with training, and it can be, there are challenges with that. But I think once you finish training, you can have a really, there's such a variety of things that you can do, which means that you can have any, the different types of lifestyles that you however you choose to live your life, you can probably find a way to fit your career around that. And so, I think if you're interested in it and if you want to do it, I think it's a really great profession. I'd strongly encourage people to do it.
Well, thank you so much for coming on today. It's been such a pleasure to chat to you about medical school, about your career, about psychiatry. We've really enjoyed listening to your insights. So thank you so much.
Oh, no problem. Thank you so much for having me.
Easy. Nice. Good job.